I'm just really thrilled, to welcome Howard Schubiner here to our group today, and just thank him for, taking this time to share what he knows in this new science, this new way to look at pain and chronic illness. So he's going to talk about his work and also leave room for questions. So, Dr. Howard Schubiner, I'm going to let you take it away.
Thanks so much, Ellen. That was great. Thank you guys for having me. I'm Howard Schubiner. I'm an internal medicine doctor in the Detroit area. I'm a clinical professor at Michigan State University College of Human Medicine. I work with Dr. John Strax at Cormendi Health in Chicago. That's where I see patients. I see patients virtually. Uh, and what I'm going to talk to you is about you, but I want to start out just talking about me for a second. I'm writing a new book, and as I start the book, I'm talking about the fact that I was at a crossroads in my career about 23 years ago. And I had done a lot of different kinds of things, done a lot of research. I was a full professor at Wayne State University College, School of Medicine, but things weren't, I don't know, I was just kind of dissatisfied. I had a fair amount of stress in my life, and I switched. I moved to a different hospital. I don't even know why I did it, but I did. And if someone had asked me, do you want to? I had worked in several different areas, but I was looking for something new. And if someone had asked me, if you want to work with people with chronic pain, I would have said, no, thank you. Would you want to work with people with chronic fatigue? And I would have said, no, thank you. I admire people who work with people with chronic pain and people with chronic fatigue, but it's hard. It seems like a difficult place to go, a difficult place to be for a physician. And can't even imagine what it's like to be as a patient, because what I saw in the clinics was people who suffered for a long time and weren't getting better. And we're trying so many different things to get better, and we're getting better. And how hard is that? How frustrating is that? It's horrible. And uh, what's fascinating is that now this is my work. This is exactly the people that I love working with. What changed? How could that be that, you know, the same person, and was a famous guy named Amos Tversky, and he wrote, good science is about seeing what's there to see, but other people can't see. And I think what the situation in the field that you guys are embroiled in, enmeshed in and suffering with chronic fatigue, long COVID, chronic pain. Uh, some people also have anxiety and depression, I'm sure. Um, is that there's tremendous odds about what's going on. Nobody really knows what's going on. And there's opinions that are so diametrically opposed that it's got to be so difficult being stuck in the middle and being stuck. Uh, and what Ellen was telling me is that her recovery started with a click moment. There was one moment that she had where something changed, where she began to see things differently. For me, the reason I got into this field was the same, amazingly, the same thing that happened to Ellen. Somebody gave me the same book that she read, Dr. Sarno's book called The Mind Body Prescription. And I read that book in 2002. And I said, that's interesting. I wonder if this makes sense. I wonder if this is real. I wonder if this will help people. And I went to work with Dr. Sarno for just a few days. And I came home and I just started talking to people. And I started reading and I started learning. And I started learning about things that I had no idea existed. I was learning things about the brain and the body that were not taught in medical school, that were not taught in residencies, that very few doctors are aware of. And then I started seeing if this would help people. And it helped people. And it was amazing. It was incredible. And all of a sudden, I was like, do I want to work with people with chronic pain and chronic fatigue? Yes, please. Yes, please. This has been it's amazing. It's been the most gratifying work that I've ever done in my career. And it all starts with a click moment, a moment when something seems different, when you can see things differently. And Is anyone here familiar with a young woman in Britain named Fiona Symington? Did you ever hear of Fiona? So I met Fiona a couple weeks ago when I was in London. But I talked to her before. I met her in person, but I talked to her before, and she has her stories online. She started having pain when she was 9 years old, had chronic pain for a decade or so, and nobody could figure out what was wrong with her. Pain had spread all over her body. When she was in her early 20s, she got a couple viral infections, a couple more, and she got chronic fatigue, and the fatigue got worse and worse and worse and worse. And 14 years after that, so now she's in her mid 30s, she's been suffering with chronic pain since she was 9 and chronic fatigue since she was 21, and now she's roughly 35. And she was very clear. She knew that she would never get better. She knew that her disease was physical and structural, had nothing to do with her mind or her brain. She knew that anybody who said that she could get better was lying to her, poisoning her, bullshitting her, gaslighting her. She knew that that she had a disease of her mitochondria. She knew that she couldn't walk more than around the block without paying for it for 2, 3, or 5 days in bed, and this was her life. And it was incredibly sad, incredibly horrible, but at least she knew what she had. And what happened to Fiona is that she started getting pop-up ads in her email from an app called Curable, which is an app, a mind-body app. It says people can recover from chronic pain and chronic fatigue. And she thought this was poison. This was horrible. This was, gaslighting her, right? And so, but she kept getting more and more ads for Curable. And she finally decided she's going to join the program to prove that it won't work for her. So that's what she did. She joined Curable to prove that it wouldn't work. The thing that happened to her, though, was that as she joined Curable, she started reading what they had to say about chronic pain and chronic fatigue. And as she started reading it, she started thinking about it, and she started looking at her own life and her experiences. And what happened to Fiona is that she started to reflect on the fact that almost everybody she knew didn't get better, but there were a few people that did get better. How did that happen? How could somebody all of a sudden get better and nobody else could? And so that was odd. It was a discrepancy, right? And then she started looking for more discrepancies. And the discrepancies that she found were that on some days she could walk 5 steps and be completely wiped out. And other days she could walk 25 steps and be not that bad. That's a variation. That's a discrepancy. Why would that occur, right? And then she kept doing that and looking at it more. And some days she could walk 2 steps and be totally wiped out. And some days she could walk 2 blocks and feel not that bad. And then the next day she could walk 2 blocks and feel horrible. Variation. What causes variation like that? So what happened to her, she had a click moment. She realized, wait a minute, maybe there's these 2 explanations for what's going on. One is I have a disease that's incurable, that will never get better, obviously, that is structural and is always going to be the same. The other idea is the brain is causing these sensations that I have that are real. They're not imaginary. They're not fake. They're not all in my head. But it's the brain causing them. And if the brain is causing them, it's more likely that there will be variation because the brain's neural circuits can turn on and off. The brain's neural circuits can change on a dime. Whereas structural disease, if your mitochondria are dead, they're dead. They're not going to turn on and off day by day. And this is how I think of things as a medical doctor. And this is how I evaluate people, because I've seen enough people with structural illnesses, cancer, tumors, infections, fractures, and their symptoms don't change day to day. They don't change hour to hour. And so that's what happened to Fiona. She eventually made a full recovery, and she's going back to school now, and she has her life back, and it's incredible. And the reason is that what I wasn't taught in medical school, what very few doctors are taught, is how the brain works, because you can't understand pain or fatigue if you don't understand how the brain works. And the brain works by something called predictive processing. And predictive processing is a incredible, incredibly mind-blowing concept that it turns out to be true. It's not woo-woo, but what it is that our brain creates what we experience. That sounds crazy. If our brain created what we experience, I would just tell my brain to make me a millionaire. What was I talking about? Predictive processing.
Yes.
So how do we see? Do we see with our eyes? No. This is the weirdest thing in the world. Our brain creates what we see. And the reason we know that is because you can see in your sleep when you're dreaming, when your eyes are closed. And so the light, can you hear me?
Yeah, I'm muting everybody now. Oh, shoot, I muted you.
Light, okay, I'm back. Light comes in our eyes and our brain creates the images. And our brain creates the images because our brain needs to see things immediately, quickly, to protect us from danger. And so if your brain has to filter out 99% of what we see, because it's not important. What's important is what's important. And the brain has a hard job in doing that. But the point is that sometimes when we see things, we're seeing things differently from what other people would see them. Someone who sees a crime being committed often picks out the wrong person at the police lineup. And it's the same with hearing. All you have to do is listen to songs to realize you're hearing things that are not exactly there, because our brain is trying to catch up and trying to hear stuff. And what we feel is created by our brain. So this is the weirdest thing in the world, right? How can what you feel be created by your brain? Well, it turns out that when you touch a hot stove, it's not your finger causing pain. The finger sends signals to the brain, but the brain has to interpret them. And the signals are not pain signals, they're danger signals, which means that someone can have an injury and have no pain. And millions of people have experienced that. If you can have an injury and have no pain, that means that your brain is deciding whether to turn on pain or not. Pain is a decision made by the brain. And this is hard neuroscience. It's not woo-woo. And fatigue is exactly the same way. Fatigue is a decision that is made by the brain. When you get a viral infection, most people get tired, but not everybody gets tired. Some people get tired, and some people get much more tired than other people when they get a viral infection. The viral infection typically will cause diarrhea or vomiting. The viral infection will typically cause, runny nose, cough, sore throat. That's due to a direct effect of the virus. The fatigue is not due to a direct effect of the virus. The fatigue is due to the fact that the brain is recognizing that you're sick and turning on fatigue to help you rest and recover. It's a safety protective mechanism. Pain is a protective mechanism generated by the brain. When you break an ankle, your brain gives you pain so that you'll know not to walk on a broken ankle. Okay? So right now, how many of you are thinking like, this guy is totally full of shit? This is crazy, right? It's crazy. And when I learned it, I was thinking the same thing, like, this is crazy. Who came up with these ideas? And the neuroscientists who do, and you can read hard neuroscience about this. If you read Lisa Feldman Barrett's book, How Emotions Are Made. If you read Andy Clark's book, The Experience Machine. If you read Dave Robson's book, Prediction something. If you read Eagleton's book, Live Wired, these are amazing stories about the power that the brain has over us. And most people have no idea how powerful that is. And it's all happening behind the scenes at a subconscious level. And so once you begin to open your mind to that idea, then what you want to do is look more deeply at, well, what disease do I have? And what is the evidence that makes me think that it's either a structural disease or a learned neural circuits in the brain kind of problem, what we would call a neuroplastic problem now, or maybe it's some of both, right? And obviously it can be some of both. So what do we do then? So once you've opened your mind to the idea that the brain can create severe pain, 10 out of 10 pain, the brain can create severe fatigue, 10 out of 10 fatigue. The brain can create brain fog and dizziness and ringing in the ears and nausea and abdominal bloating and diarrhea and constipation and anxiety and depression. All these things I've seen in my practice for the last 23 years now of doing this work. All these things I've seen in my practice and help people to actually overcome them. And everybody has slightly different combination of the symptoms that they have. But the key question is, what's causing them, right? Because if you get the wrong diagnosis, you get the wrong treatment. So when we talk about long COVID, what do we know about long COVID? We know that nobody knows. We know that nobody has a magic cure for it. We know a medical cure. We know that there are lots of theories about it, but nobody's come up with an easy medical cure. And we know there's lots of treatments for it. Ellen was telling me she had a lot of different treatments that she tried. I'm sure most of you have as well. Who wouldn't? If you're desperate, if you're suffering, you want to try any treatment that would make potential sense, right? You would. And and so there's a lot of data on long COVID talking about inflammation in the body, inflammation in the brain, blood clots, immune system abnormalities, cytokine abnormalities, right? There's a whole host of literature because scientists have been working hard to find out what's wrong. And what we found at the same time as all that literature is out there, there's also research that shows that when you examine people with long COVID, for the most part, most people with long COVID didn't have the severe ICU intubation kind of experience with COVID. Some people with long COVID had other viral infections that weren't COVID. Some people, so it gets confusing. But what you find when you examine people with long COVID is their hearts are normal, their lungs are normal, their brains are normal, their muscles are normal, their nerves are normal, the lab tests are normal, and it's so confusing. And so how can you reconcile that? And the thing that I would suggest to you is that the abnormalities that are found in blood clotting, the immune system, the cytokines, the inflammation, those abnormalities are there and they're real, but they're not actually the cause of the symptoms. They're correlative rather than causative. And this is a huge, huge factor when you look at science. Science needs to determine if something's correlated or causative. And I've been doing this work for all these years, and this is what I've seen. So many times people are told their back pain is due to degenerative disc disease in their back. It turns out degenerative disc disease in the back is not causative of back pain, it's correlated with it. It occurs, but it's not the cause. And so when you think that the cause of your severe back pain is degenerative disc disease, then the message is, of course, you're never going to get better. If you think the cause of your chronic fatigue and long COVID is mitochondrial abnormalities, that's a disease, structural disease from which you can never get better. And those ideas that telling people that they're incurable and they can never get better, on one hand, you could argue, Fiona Simonton would have argued, well, at least I know what I have. What But it also can have the effect of making people worse because there's a vicious cycle. The more someone has a symptom and the more they fear it and focus on it and pay attention to it and fight it and struggle with it, the worse it can get. And most people with chronic fatigue syndrome and long COVID get worse over time. Why would you have an infection and then get worse over time? It doesn't actually make sense medically to me. But getting worse over time is very common in the people that I've seen all these years because of this vicious cycle that I'm talking about. And so, um, and so there is hope here, as you probably are aware. Mike Danino, my colleague, Ellen's friend at Brigham there in Boston, has done a small study. And what he found in that study was that the majority of people recovered from long COVID using this kind of mind-body approach. And one of the most important things that he found in that study is that the post-exertional malaise improved in I think it was 12 of the 13 people who had it. Of the 13 people who had post-exertional malaise, 12 of them had dramatic improvements in post-exertional malaise after the treatment. And this post-exertional malaise, as you're probably aware, is a big sticking point in the debate, in the argument, in the viewpoint. Is it structural or is it neuroplastic or not? And he proved in his study that those folks could get better. And what happened to, and so if you're willing, if people are willing to kind of step back and take a new look, take a look in a different way, then they can look at their own situation and make up your own mind. Because what I say doesn't mean it's right for you. What Ellen says doesn't mean it's right for you. What's right for you is what you say, is what's most important for you. And you know yourself and you know your body. What I'm suggesting is that we look for these variations. So Fiona, as I was saying, saw these variations, right? And that changed her view of what was happening to her. I had a guy I met a while ago who had severe foot and back pain, and he couldn't stand. So if he stood for a few minutes, the pain went crazy. Horrible, horrible pain. And this was 25 years that he was suffering with this pain. 25 years. He was so bereft. He couldn't do anything. He was in a recliner all day. He was depressed and anxious on top of it, as who would, of course, he would be. And he had like a level 5 back pain one day, and he was walking into a pharmacy. And he walked into the pharmacy and he saw a long line of people waiting to get their prescriptions. And within 2 seconds or 5 seconds, his pain went from a 5 to a 9 on seeing the line. And that was his click moment. He was like, oh my God, I had heard about this brain body connection, but I didn't believe it. It didn't make any sense to me. But now I can see it. It makes sense. And it's happening to me because he had his mind open a little bit, and then he looked for that click moment. And the same thing happened to Fiona with the variation in how the fatigue can vary from day to day. And so we have to look very carefully at all the evidence that everybody has in their own life. I just saw somebody popped up and saying, well, Ehlers-Danlos is structural, right? Well, Ehlers-Danlos has a variation. It's a spectrum. Some people with chronic fatigue syndrome have hearts that are have very severe congestive heart failure and very severe lung failure, and their fatigue is going to be static because their hearts and lungs aren't working. Same with Ehlers-Danlos. There's some people with Ehlers-Danlos syndrome have the severe genetic form of it, for which they can have what's it called? Subluxations of their joints, but this is extremely rare. The vast majority of people with long COVID don't have the chronic lung and heart disease that we're talking about. The vast majority of people diagnosed with Ehlers-Danlos don't have that kind of genetic abnormality. And so the vast majority of people who are diagnosed with Ehlers-Danlos have mild hyperflexibility, but that's actually correlative and is not the cause of their symptoms. And how would we know that, though? That's the question. How would we know? You look for the variation. So I have something that I've written about called the FIT criteria. Are the symptoms functional? Are they inconsistent? Are they triggered? FIT. And I've written about that. I can send Ellen articles about it, papers about it. But once your mind is open to say, well, geez, I wonder if my condition, how much of it is structural that is never changing, can never get better, and how much of it is neuroplastic that is changing and can get better. Let me look at that. And so, is it functional? Are this have doctors found a clearly identifiable cause for the disorder? In long COVID, we haven't. Again, making sure the heart's okay, making sure the lungs okay, making sure the blood count's okay, etc. Uh, are the symptoms in a widespread area? Are they very widespread? And are they getting worse over time? Um, are the symptoms variable, inconsistent? Are they like, as I was saying before, so some days you can have much more, some days less. Uh, are they triggered by innocuous stimuli? Are they moving around? So some days you have maybe more of fatigue, and other days it's more brain fog. Some days it's more GI symptoms, and other days it's more dizziness, right? So if you see some of that kind of variation, that's another kind of variation where we can say, geez, that doesn't seem structural. That seems like the brain could be turning on and turning off different neural circuits. And then the triggered. Is it triggered? Is it like Gary found it was triggered by standing? But you can find that it's triggered by imagining standing. One of the tests that I use for people is to have them imagine walking, have them imagine exercise and see what happens. When you imagine doing an activity that's triggering the symptoms, you're not actually doing the activity, but you're causing the brain to think that you're doing it. And when the brain will frequently turn on the sensation, maybe it won't be as severe, but it'll frequently turn on the sensation of fatigue or dizziness or other symptoms when you imagine the stressful situation or you imagine the activity that is causing it. People who get worse with the weather, people who get worse with computer screens, people who get worse with heat or cold, these are all, or the wind, these are all symptoms, uh, uh, information that we use to help put it into one category or another. And when you find that evidence, then there may be some hope, you know? When you find that evidence, maybe there be some hope because other people have gotten better. You know, there is some research from Dr. Danino who shows that some people have gotten better. Even people with severe post-exertional malaise have gotten better. And so this is all we're saying is that there's competing viewpoints, and if for folks who are suffering and they haven't found help from the traditional medical profession, this is something that is low cost. It's not invasive. There's no risk. There's no, risk of side effects from changing your mind, kind of. Uh, and some people, uh, you know, and then the other thing that people can look at is they can look at their life, because some of the risk factors for long COVID are other mind body type or other neuroplastic disorders. So often people who have long COVID prior to getting it had histories of irritable bowel syndrome, histories of headaches or migraine headaches, histories in the past of eating disorders or anxiety or depression or back pain or pelvic pain, right? And so that kind of gives a clue. And people with long COVID, some of them have histories of childhood trauma. Fiona had a history of childhood trauma that she never thought played any role in it. But it turns out research shows that people with the brain tends to turn on symptoms when it's feeling endangered, and people who've been endangered. Women have higher rates of emotional abuse, sexual assault. Women have higher rates of all harassment in the workplace. Women have higher rates of all sorts of traumatic things in their life uh, that can play a role. And again, I'm not saying this for everybody in every situation. What I'm saying is that each person can take a look and look at their lives and see if this makes sense for them. So that's what I wanted to tell you guys. And I'm going to look in the chat and see if I can answer some questions for you. Let me start at the beginning. record. Thank you. Uh, uh,
Yeah, and if you have a question, you can just raise your hand like
someone
Nathan.
says they don't think I'm full of shit.
It's a good thing.
Uh, and so the question is lack of oxygen creating fatigue? Check your oxygen. You know, that's a theory. Is it true for you? You can get an oxygen meter, you know, and see how you feel with different levels of oxygen. The oxygen may change somewhat. You know, if your oxygen is going down into the low 80s, well, you have an oxygen problem. Most people with long COVID, their oxygen levels are not going into the 80s, but check it out and see if that makes sense for you. You know, uh, who's the person in Boston? Well, it's either Ellen knows all the people in Boston. You can ask her. What if the brain is right and you do need lots of rest to heal? Uh, right. Well, that's a great question. Uh, if the brain is saying that you need to heal, then you need rest to heal, then true, you need rest to heal. But for how long? Right? That's the question. Right. And so what happens with these neural circuits is that our brain creates our experience based on our past experience. That's predictive processing. And so when you're getting up to walk, the last week, the last month, the last year, the last 5, 3 years, whatever it is, your brain you've been tired after walking. So of course your brain is going to give you tiredness after walking when you walk, because that's its past experience. That's what it knows how to do. So in order to change that, we have to give the brain a different message. And that's what pain reprocessing therapy is giving the brain a different message about what's wrong with you. And so, many of the symptoms that I would suggest that the symptoms of the people that I've seen who had long COVID were being created by their brain. Let me give you an example of that blew my mind. Okay, so I saw a woman with long COVID a couple years ago, and she was suffering for about 9 or 10 months, and she was very tired, and she had a lot of cognitive disability and a lot of symptoms, but she was seeing me, and she was thinking that what I was saying made sense to her. And I saw her for my first visit for 2 hours, and I saw her 2 weeks later, and she was getting better in 2 weeks. She was about 60, 70% better. It was amazing. She was so happy. But what was fascinating is she had loss of sense and smell. Okay. So many people with acute COVID have loss of sense and smell, right? Taste and smell, sorry. And so we believe that's due to direct virus effect on the receptors in the nose that help us smell and taste, right? So that makes sense. That sounds like a structural problem. Well, she had loss of sense and smell for 9 months, right? Or 10 months. And then when I saw her, the next day after I saw her, her sense of smell and taste came back. The day after that, her sense of smell and taste went away. The day after that, it came back again. The day after that, it went away again. This is mind blowing, right? How in the world could the loss of taste and smell turn on and off like that day by day? Because it had been caused by the virus initially, but now it wasn't being caused by the virus anymore. Now it's being caused by learned neural circuits in her brain that could turn on and turn off. Okay. And so please don't think that if this just because a symptom is severe or just because a symptom feels structural, of course it's going to feel structural because the symptoms that the brain creates are real. They're the same symptoms as if it would be occurring due to a structural injury. Because I forgot to tell you this, research shows that when you do fMRI on people's brains, when you give them a structural injury in their body and scan their brain, and then you give them an emotional injury and scan their brain, you get the same thing. So what the brain is causing is real. It's not imaginary. That loss of sense of smell and taste that she had was real, but it was caused by her brain. Um, and so the question is, can you prevent reinfection? Do you need to prevent reinfection? That's the question. And so the point is that why do people get worse when they get a reinfection? There's two answers to that. One, because the infection is so severe that it causes the whole symptoms of everything again. Number two, the infection triggers the brain to make the symptoms worse. Okay, the infection can trigger the brain to make the symptoms worse. The same way that Gary's pain was triggered by seeing the line in the pharmacy. The same way that people's pain can be, or that people's fatigue can be triggered by walking around their house. So, that this is really mind-blowing stuff that I'm saying. And again, I don't expect you to just believe me. What I expect you to do, or I suggest that you do, is look at your life, look at these materials.
I just want to again say thank you so much because I think you really shed light on this approach. And I, agree that it's so funny how we kind of fall into these things. I never would have thought that this could be, something that could help either. And, there's a lot of people on this call right now who have gotten better through this. And so I just urge if anyone wants that, you can't, like you said, you can't actually have harm from it. you know
And just one more thing
yeah,
I was thinking about my answer to Joy. And so
yeah,
what a lot of times when people get better quickly, the reason people get better quickly is because they're using the pain reprocessing type of treatments, where you're giving your brain these corrective messages and the brain hears it and you get better. But for a lot of people, it's actually that that can go a significant part of the way, but can't go all the way. And that's why we developed emotional awareness and expression therapy, because emotional awareness and expression therapy is helping people deal with the underlying emotions that may have been there in their lives, may have been there from their childhood, might be there from reactions to people in their lives, to their doctors, to their illness, etc. So the emotional components of it can be really important. And people who are doing this work realize that the pain reprocessing is enough isn't enough for a significant, maybe half the people, or more of the people. So
right.
anyway, so the emotional awareness and expression therapy, I've written about it. It's in my books, it's in our research. We've done research on it showing that it's effective, in fact more effective than standard cognitive behavioral therapy for chronic pain. We don't have any studies on EAET for long COVID or fatigue as yet, but that's an important area as well. Anyway, I'll stop.
Right. And those are in the emotional awareness therapy part is in both of your books, Unlearn Anxiety
Yes,
and Depression and Unlearn Pain.
correct.
All right. And did you say you were going to send me a paper or something that maybe I could distribute on that also?
I will.
Okay, thank you. Just trying to squeeze out whatever I can. But anyway, thanks everybody for coming here. Thank you for taking this time again. I really, really, really appreciate it.